I think we actually kind of have two speakers today. Yvonne Golightly is going to kick things off. Yvonne, many of us know well. She is currently an assistant dean or the assistant dean for research and a professor in the physical therapy program in the College of Allied Health Professions at the University of Nebraska Medical Center. She, as many people know, has had a really long relationship with Thurston Arthritis Research Center and does some excellent work related to osteoarthritis epidemiology. And then Liubov Arbeeva is also going to be presenting with her. Liubov is a biostatistician at the Thurston Arthritis Research Center, and we look forward to hearing from you all today. And I'll let you all go ahead and give your title and get rolling.
Okay, thank you, Kelly. I'll get my slides going here. And can everyone see the slide okay? And you don't see my notes? Okay, great. All right. Well, thank you for that introduction, Kelly, and thank you for the opportunity to present some of the knee osteoarthritis research that my colleagues and I have been working on. So you may notice that I have a subheading to our title. So the title of today's talk is Influence of Sociodemographic and Clinical Features on Ground Reaction Force Variability During Gait Among Individuals with Symptomatic Knee OA. But that subtitle I have here because I'm going to broaden this talk today somewhat beyond just this work. And what happened was while I was preparing for this session, my colleague Liubov, a brilliant biostatistician who will be presenting with me today, we've also been working on another study that uses a similar analysis approach. So I thought for today's talk, it would be interesting to present some of this work also on using a useful machine learning approach for studying knee osteoarthritis. And it's called Angle-Based Joint and Individual Variation Explained, or AGIVE. So we'll be telling you a bit more about it today. And so first, I will talk about how we use this method to study ground reaction forces. And then I will, in the second part of this presentation, I'll introduce our other study. And Liubov will show the use of AGIVE to analyze biomarker samples in a military cohort with ACL injury and knee osteoarthritis data. So starting with our first study, and these are my colleagues who worked with me on these analyses. So for some background, as many of you know, knee osteoarthritis is one of the most common chronic conditions in adults and a leading cause of disability. And we know there are many different types of OA, and phenotyping is a way that we can characterize different subgroups so that we can inform clinical research and potential treatments. And one category of knee OA is related to abnormal mechanical joint loading during movement. So this could be having a higher body mass or abnormal alignment of a joint or altered patterns in movement that may play a role in knee osteoarthritis. So I'm showing ground reaction forces here because they were the focus of our present work. And there are three types. There's vertical, anterior, posterior, and medial lateral. And for the vertical ground reaction force, which I'm showing here circled in red, a positive value in this force is the force plate pushing upward on the body. And you'll notice when you're looking at the curve here, if you're following my arrow, what we have is a bimodal curve. And the force data that are collected in walking trials are typically simplified into a specific or discrete measure for analyses. And for example, with a vertical ground reaction force, we may often simplify just by reporting the peak or the highest point on the curve, talk about a minimum force, or even calculate the area under the whole curve. And these are efficient ways for us to summarize the data, but we can end up missing information about the whole curve itself. And just to familiarize you with the anterior-posterior ground reaction force, so it is in this direction. And if you're looking at the curve for this force during stance, Initially, we have a braking force, a slowing down after the heel strikes, and while the foot is going into a flattened position. And then when we go into toe off, we have a push off force. And then we have the medial lateral, which is a side to side motion. Initially, we start off with a more laterally directed force, and then it goes medial as we go through stance. So with our current study, we wanted to first identify distinct movement phenotypes using the ground reaction force data that we had among a group of people with knee osteoarthritis. And we used a data-driven machine learning approach, so the AGIVE that I mentioned earlier. And we used this to help us study the relationship of modes of variation in the ground reaction force curves. Specifically, we wanted to look at amplitude, which is the height of the curve, and phase, which is the timing of the curve. And we wanted to compare these with sociodemographic and clinical features. And all these data were collected at baseline. So the data source for this study was the Intensive Diet and Exercise for Arthritis study that's also referred to as the IDEA study. And two of our co-authors on this work, Steve Messier at Wake Forest and Richard Loser at UNC, conducted this study. And it was a single-blind, 18-month randomized controlled trial of 3 interventions. There was exercise only, intensive diet, induced weight loss only, and then a combination of both. And the IDEA study included 454 community-dwelling adults who were at least 55 years old, and they were enrolled from 2006 to 2009. And those that were included needed to have at least mild to moderate radiographic tibiofemoral OA on one or both knees, needed knee pain on most days, BMI of at least 27, and then a sedentary lifestyle that was defined as less than 30 minutes per week of exercise over the past 6 months. And for baseline measures, these were all collected before intervention. They included a walking analysis and then collection of sociodemographic and clinical data. For the walking analysis, the participants wore cushioned shoes that were provided by the laboratory, and they walked at their preferred walking speed on a walkway over a force plate. And they had to do 3 successful trials on each limb for each participant. So the participant level data are shown here in this table, and these were all collected at baseline, as I mentioned. And there are 40 variables. They include sociodemographic characteristics like age, sex, race, and then we have many clinical characteristics here that we felt may be associated with knee forces. So we have anthropometry measures, pain, physical function, gait, falls, self-efficacy and satisfaction, physical and mental health measures, radiographic knee OA, inflammatory biomarkers, and then a number of comorbid conditions. And we ended up using an analysis approach that's called objective-oriented data analysis, which is a data-driven machine learning approach that considers the full data curve. And we felt this was very important for looking at our ground reaction force data. And this set of methods can be used to determine modes of variation in both amplitude, so in that height, and then also in phase, so the timing of gait curves. These curves here are not a vertical ground reaction force curve, but I think it helps illustrate at least what we're going to be doing when we apply this method. So you have heard me mention about amplitude and phase, and you're going to hear quite a bit more about it when I present the results. But just to go into a little more detail about the importance of amplitude and height, when we're talking about amplitude in the context of a vertical ground reaction force, what it represents is this compressive force that happens during gait. While the phase or the timing, what that illustrates is this variation in the rate of loading. So how quickly or slowly do we load the limb? So to start to explain what we're doing when we apply this object-oriented data analysis to the ground reaction force data, we'll start with the figure on the left, which are original curves as data objects. And these curves are from different people, and the rainbow coloring here represents where you see red, that is the fastest speed. And you'll notice that on this side, the curves aren't aligned. And what we need to do is use a curve registration method to align these curves in a particular way, which you see on the right. And I give credit here to Elise Borgert, not only for this slide, but for spending a lot of time helping me understand the methods for this approach. I will admit this is not my area of expertise, but I definitely appreciate this whole process. So the curve registration approach that we used is called Fisher-Rao, and what it does is it uses information about the amplitude on the vertical axis and the phase on the horizontal axis. And variations in amplitude and phase are separated and captured by align data and then what we call warping functions. So these warpings are functions that we apply to the original data that stretch or compress the original curves and summarize that phase variation to try to get the peaks perfectly aligned so that then we can analyze them. So we use this approach with our vertical, anterior, posterior, and our medial lateral ground reaction force data. But the way that we treated it, rather than treating all of them as separate planes of motion, is we considered them to be a single multidimensional curve. Because what we're really talking about with the ground reaction force is it's a single measure that we often call the normal ground reaction force that moves through 3 dimensions of space. So we applied this Fisher-Rao registration and obtained our common set of warping functions, and then we applied those to align our curves. With our data analysis, we identified modes of variation using a principal component analysis. And with a mode of variation, what we're doing is we're summarizing one component of variation in the data. And so this principal components analysis allows us to look at interrelated variables and transform them into a new set of scores, which we call the principal component score. And you'll be seeing more with that as I show some of the results. For our analyses, we determined modes of variation that reflected the amplitude of the different ground reaction force curves, as well as the phase. And then next, to determine the relationship between those ground reaction forces and all the sociodemographic and clinical features data that we had, we used AGIVE. And what the AGIVE does is it treats the ground reaction force data and all those clinical data like distinct blocks. And so then we're able to determine how those blocks vary together and how they vary separately. And this will all make more sense as we go through results here soon. One of the things that we did need to do before moving forward was use a squared singular value diagnostic plot for the movement scores and the clinical data blocks. And so here, looking at the black lines, is what we call the squared singular value. And the red dashed line is the threshold, where we consider everything that's to the right to be distinct from the random noise to the left. So we see that there are 4 black lines here on the right of the red line, and that suggests that we have 4 joint modes of variation, which we will call joint components. So now we will look at the results for each of those joint components. So this one is joint component 1, and we see the loadings of each component for the data blocks for the clinical traits on the left and the movement scores on the right. And they indicate which features were important contributors to each mode of variation. So loadings that are in that colored in red are in the positive direction, And any of those loadings, so those bars that go that are blue are in the negative direction. And the length of that loading bar indicates the magnitude of contribution to the mode of variation. So what it means is if you see a greater length, then you're looking at a greater contribution. And if we start on the left with the clinical traits data block, you'll see that walking speed, and then this one is the 6-minute walk distance that are both in blue, were the most important, followed by gait efficacy and balance confidence. And that's all in the negative direction. So I will refer to this as the better movement. Then up here in red, we see fear of falling and poor WOMAC function had the larger positive loadings. So we can refer to that as worse movement. And then if we look at the right data block for the movement scores, what we see in blue here, the first mode of amplitude variation of the vertical ground reaction force, it's large and positively related to that walking speed that we saw in the clinical traits block, since both are in that same negative direction. So the way that we can interpret this is better movement and higher vertical ground reaction force height are related, and that makes sense to us. We know that the faster we walk, the higher the vertical ground reaction force. So now we can look at those curves in each plane of movement, and these are results like what we would expect. So if we start by looking at that vertical ground reaction force, the faster walkers, those better movers, are shown in blue. And we see that they have a greater force in early and late stance with those higher peaks, and then less of a force in mid stance. And if we look at that red vertical ground reaction force, this is those worse movers, the ones that we saw that had higher loading for fear of falling. And what we may be seeing here in the shape of this curve is a shuffling gait. If we look at the blue curve for the AP ground reaction force, we see that there's a deeper valley and a higher peak for these faster walkers. And we don't see much of a difference for the blue or red medial lateral ground reaction force curves. So now moving on to joint component 2, looking at the clinical traits data block first. In red, male sex has the largest magnitude positive loading, followed by greater waist circumference, older age, severity of radiographic knee-OA, and a greater body weight. And then if we look on the right at the movement scores block, the largest positive loadings in red were for those first 2 phase modes, and then the third mode of vertical ground reaction force amplitude variation. So looking at both blocks, the first 2 phase modes and vertical ground reaction force amplitude mode are highly positively related to male sex. And now if we look at the ground reaction force curves, starting with vertical ground reaction force, looking at the red curve, which was associated with male sex, what we see is a higher first peak and a slightly lower second peak. And the middle valley here occurs just a little bit later, so the delay with the phase. Looking at the AP ground reaction force, we see the curve this red curve has both a small braking force and then a small push-off force. And then looking at the medial lateral ground reaction forces, we don't see much of a difference here. Overall, they're not huge differences in these curves, but these results align with our knowledge that there are differences in walking patterns by sex. And then for joint component 3, we see greater loadings in red for the clinical traits that are related to greater body mass. So this is first looking at the higher body weight, greater hip circumference, higher BMI, and greater waist circumference. And then looking at the loadings for the movement scores block in red, we see that the largest loadings are for the second and the fourth modes of amplitude of variation for the vertical ground reaction force curves. And then for looking at these ground reaction force curves, first with the vertical, what we see for the red one is that's related to this greater body mass is what's called a heel strike transient. So it's this bump before the maximum first peak, and it's followed by a lower valley and then a lower second peak. We don't really see any differences when we're looking at the AP ground reaction force curves. And then for the medial lateral ground reaction force, what we see is a greater lateral force throughout for those with greater body mass. So how does this compare to what we already know? There's not a lot of literature in this area, and of the studies that we found, often the samples are smaller, and the results do seem to vary, but we did see that there's some agreement where lower vertical ground reaction force peaks among those with obesity compared to those without obesity. And then we also saw that there were, in other studies, no remarkable differences in the AP ground reaction force magnitudes, which is similar to our study. And then for the medial lateral, we saw in the literature one study where they were actually medially directed among those with obesity. And then there was another study where they only saw it laterally directed, just an initial loading. And then our final component, the fourth joint component, the features that were related to worse knee-OA or greater severity of radiographic knee-OA, greater pain and poor function, had the highest positive loadings here in red. And while clinical traits that were related to poorer health, so waist circumference, greater BMI, and a history of cancer, had the largest magnitude negative blue loadings. And then we see for the movement scores block in red that the first mode of the medial lateral ground reaction force amplitude had the highest loading. And in blue, we see the third phase mode, as well as the third and fourth modes of vertical ground reaction force amplitude had the highest loadings in that negative direction. And then looking at our ground reaction force curves, the red curve that represents that worse knee-OA had this earlier rise into a higher first peak of the vertical ground reaction force, and then a slightly later decline into a flatter valley. And the blue vertical ground reaction curve, that's that poorer health group, demonstrates a slight delay here in that first peak. For the AP ground reaction force, the rise in the anterior peak on that red curve for the worst knee-OA occurs a little bit later. And then for the red medial lateral ground reaction force, which is representing the worst knee osteoarthritis, that reflects this overall pattern that's more in a lateral direction. So just to summarize these results, joint components 1 and 2 align with what is known about the effects of walking speed on ground reaction forces and differences in gait by sex. The results for joint component 3 add to a literature that shows some similarities, but there also seem to be some differences by study. And then results for joint component 4, I think, we worked on trying to understand these. There wasn't as much literature related to looking at these groups, but we do feel that it, when you're doing these types of biomechanical studies, that it is important to consider the knee-OA severity and other health conditions, but more research is needed to confirm those findings. So I think the big takeaway is this utility of the object-oriented data analysis that we use for the gait curves to align them, and the AGIVE in this type of analysis, looking at movement and clinical traits. And we did see distinct relationships between the clinical traits with ground reaction force patterns that we feel may suggest potential biomarker phenotypes. And there's always room for more research. So future research directions would include doing similar analyses in other cohorts to compare our results with theirs. Longitudinal analysis, since this is a cross-sectional analysis in our present work. And then also with the IDEA study, we have opportunities to look at other biomechanical measures, especially looking at joint forces and moments. So I'm going to switch over to our other study now, looking at ACL injury and knee osteoarthritis in the US military. To begin with, it has been established that knee injury is a major risk factor for knee osteoarthritis, as I'm sure many of you know. And this is a quote from a 2007 paper that at 10 to 20 years after the diagnosis, on average, 50% of those with diagnosed ACL or meniscal tear have osteoarthritis with associated pain and functional impairment. So this is a model of how to think about the life course of musculoskeletal health and how injury earlier in life may contribute to later osteoarthritis, joint pain, declines in function, and disability. And when it comes to thinking about preventing this progression from injury to post-traumatic osteoarthritis, there are a few points at which we can intervene. We can prevent the injury from ever happening. We can lessen its severity at the time it occurs, or we can manage the injury afterwards to mitigate that risk for OA. And there's significant interest in that first arrow on the left, preventing that injury from the get-go. And so through a collaboration that was between the US military and our team of researchers, a study was conducted among military cadets who initiated in 2004 in order to understand these risk factors for knee injury and to then go on and do another study to look at the progression of OA after injury in this cohort. So you may wonder why there was an interest in the military population. Military officers are at an especially high risk for ACL injury. ACL injuries do occur in roughly 4 to 5 times, occur roughly 4 to 5 more times among active duty military personnel than in the general population. And 90% of the military personnel return to active duty after they have ACL reconstruction. They're young, they're physically active, and their injured knees experience a lifetime of loading from recreational and occupational demands. And the parent study is called the Joint Undertaking to Monitor and Prevent Anterior Cruciate Ligament Injury, or JUMP ACL. And it began as a collaborative multi-site prospective cohort study of risk factors for ACL injury. It recruited individuals from 2004 to 2010, over 12,000 military cadets. And since the prevalence of women in the military is lower than it is in the general population, and because ACL injuries differ by sex, women were oversampled with a final cohort of 38% women. The overall design for this study is shown here. So when cadets were entering the military academies, they completed baseline physical tests and a questionnaire. While they were in the academies, they were followed to collect data on knee injuries through the medical record and through follow-up questionnaires. And then after they graduated and began their military careers, we conducted another study of a sample of how these now officers how they were doing with their knee health afterwards by collecting knee radiographs and questionnaires. And I mentioned that physical testing was done at baseline when the cadets began in their academies. And one of the aims of the original study was to see if there was a movement risk, there were movement risk factors for later knee injury. So over 5,000 cadets completed this jump landing task where they jumped off of a box and a force plate and then jumped upward. And then data on their hip and knee movement were collected during that task. And with these biomechanical data and the tracking of new injury cases, the researchers were able to show a high-risk movement profile where those who showed more hip adduction, so with the femur closer to midline, had a 4 times higher rate of ACL injury compared to those without this movement pattern. And then with the addition of knee varus, so an inward motion of the knee, they saw that the rate was 27 times higher. And this is a different movement pattern than what we typically see happen at the time of an actual ACL injury, where there's more of this inward collapse of the knee. And what we think we're seeing is that those with that high risk movement profile, they tend to differ from this ACL injury movement profile. And we think that they are less able to sufficiently manage external knee loads whenever that foot is out wide to the side. So neuromuscular strategies for the hip may be a treatment approach. The next phase of our work was to follow the Jump ACL cohort into their military careers, and we had 2 groups. We had a knee injury group where they had experienced knee injuries either prior to, during, or after their time in the academy, and then an injury-free group. And participants were consented online and completed online questionnaires about their knee health. And we also worked with 29 military sites to set up a standard knee radiograph protocol so that we could determine the presence of radiographic knee OA. And at the time of data collection, the mean age was 28, mean BMI was 25. There'd been an average of 9 years since their injury. 39% were female and most were white. And what we found is that 16% of those with knee injury had radiographic knee OA compared to 1 person in the uninjured group. And it's important to note how young these individuals are. So what we're seeing is that approximately 1 in 6 officers with prior knee injury progressed on to knee OA by the time they were 30. And based on the questionnaire data, those with an injury history were more likely to have moderate to severe pain and more likely to have worse scores on the KOOS related to pain, other symptoms, sports and recreation, and quality of life. And so another aspect that we were interested in examining with this sample was the OA-related biomarkers. So now I will pass things over to Liubov, who will talk about her analyses on these data.
Thank you. Can you see my slide?
Yes.
Hi everyone, and I will talk about secondary analysis on a subset of military officers enrolled in 2004, 2009. We used only subset without knee injury at matriculation, and all of them had available biomarker measurements at both matriculation and graduation. So we had 149 males and 85 females, 6% were Hispanic and 85% were white. The mean age at matriculation was about 19 years. Almost 20% had injuries before graduation, and less than 15% had injuries after graduation. Serum extracellular matrix biomarkers included collagen type 2, C to C, and type 1 and 2, C1 to C, collagenase-generated cleavage epitopes, C-terminal propyptide of type 2 collagen, CP2, And finally, C and terminal telepeptides of type 1 collagen, CTX and NTX. So now I will spend some time on Archive basics. So all biomarker and demographic data were divided into 3 sets of measurements, and we call them blocks. So the first block was biomarker levels at matriculation. This is a blue block. The second one was biomarker levels at graduation. And finally, the green block is demographic, like ethnicity, race, and age, smoking status, and BMI. Just one technical detail, I transform all data before Archive, so all measures will be on the same scale and normally distributed. So the analysis framework was based on the angle-based joint and individual variation explained algorithm. We call this Archive, aiming to find shared and individual modes of variation to reveal a multidimensional data structure. By shared, I mean common to all data blocks. Originally, it was called joint variation, but I prefer to use shared to avoid confusion with joints like knees and hips. And individual is specific to each block. So Archive was developed by Dr. Maron, who is a professor biostatistician at UNC, and he's working with many researchers and clinicians, including TARC researchers, and I'm very proud to be a part of this collaboration. So similar to principal components analysis, Archive is based on a decomposition of the data into modes of variation and using loadings and score matrices for interpretation. The loadings are the weights for each original variable when we calculate the principal component. The loading matrix provides variable level information and can be used to identify the importance of each variable to each of the principal components. The score matrices, they contain subject level information and represent the original data like biomarkers, demographic data, with a reduced number of variables or principal component scores, but retaining most of the important information. Unlike principal component analysis, Archive can work with multiple data blocks and provides 2 types of modes of variation: shared variation between blocks and individual variation for each block. Because both biomarkers and demographic data represented by 3 blocks are measured on the same set of participants, it is possible to have common scores, but it is not possible to have common loadings. And I will provide you one example. A biomarker can be elevated at matriculation because of the younger age, but not at graduation because a person is older. And that can be determined by different loadings for 3 variables from 3 different blocks: biomarker at matriculation, biomarker at graduation, and age. So the loadings indicate which variables in each block vary together or individually. So now let's look at the individual variations blocks for biomarkers. I will start with the blue one on the left. And this is individual variation in biomarker levels at matriculation. And this is not related to the biomarker levels at graduation and demographic features because it was all in a shared variation. On the right, we have individual variation in biomarker levels at graduation that is not related to the biomarker levels at matriculation and demographic features. Applying Archive to the data blocks or of demographic and biomarker data collected over time, this is longitudinal analysis, allows us to answer several research questions. So first, we can determine if serum biomarkers vary with regard to demographic data and smoking status by describing the components of shared variation. We can also explore associations between individual variations of matriculation biomarker block and injury-related outcomes to determine if serum biomarkers at matriculation can identify individuals at high risk of injury. So to answer the first question, we have to look at shared variation. And to answer the second question, we have to look at individual variation in biomarker levels at matriculation. So what is important here is that Arbeeva doesn't know about injury outcomes. Remember that all follow-up data about injury and COOS scores were not included in any of 3 blocks. What is even more important, we removed the strong influence of demographic characteristics on biomarker levels from the individual matriculation block. We keep it in shared component. And it allows the discovery of other associations that may be not because of the injury, but not related to demographics. And that's the beauty of Arbeeva. So I will describe the results for men sample and the results in females. They were similar, and remember that these people were selected because they were without injuries at matriculation. So we found one direction of shared variation between 3 data blocks, and it was primarily described by older age at matriculation and graduation. So what about other demographic characteristics? So to eliminate the strong effect of age and to allow the effect of other demographics, I used age-adjusted values of biomarkers in the first 2 blocks and removed age from the block 3. Reran Arbeeva and enhanced the effect of other demographic characteristics. So this single shared direction of variation described by lower levels of cartilage synthesis and bone turnover, and clinically by higher BMI, less smoking, and Hispanic ethnicity was consistent with known associations of joint metabolism biomarkers with age and smoking. So this is to answer the first research question. So now I will move to the second one. To the individual variation in a matriculation block. So we found 3 directions representing individual variation in biomarker levels at matriculation. So let me first spend some time on Arbeeva basics and explain how to interpret these graphs. And I will start with the left part of the slide. The red and blue curves on the diagonal plots indicate the kernel density estimate for the distribution of the scores. And they are colored by injury status after matriculation. Injury is blue and no injury is red. Each dot is a person. This is individual level information from score matrices. Location of each individual in the coordinate system is defined by the individual directions shown in panels on the right. So now I will move to the right part of the slide. These loadings are variable level information. And loading plots show the amount that each biomarker or clinical variable contributed to a given mode of variation. So all these plots should be used together for an interpretation. So now interpretation. The first component in men was described by high cartilage synthesis. You can see CP2 and low cleavage of type 1 and 2 collagen, C1 to C. It indicates lower bone and cartilage degradation and suggests a protective knee phenotype. And now let's move to the left part of the slide. Men who experienced knee injuries during and after school had lower individual scores. This is a blue line. And it suggests that a low cartilage synthesis prior to injury, in particular low CP2, can be an injury risk factor. So I will also add that age-adjusted levels of CP2 measured at matriculation were higher in men without injuries during and after school completion in t-test, p-value was less than 0.05, and they were also negatively associated with incident injuries after adjustment for smoking status in logistic regression. So, which was used to confirm results from AGIVE. So, in this exploratory analysis, we confirmed known associations of joint metabolism biomarkers with age and smoking, and provided new insights into the potential of these biomarkers used singly, like CP2, or in combination to identify individuals at high risk of injury or post-injury outcomes. So, what is next? You all probably know the joke that if you torture the data long enough, it will confess. So in my opinion, AGIVE is a great way to explore data, specifically multidimensional data from different sources like genetic, nutrition, physical activity, to name a few, without having to torture yourself for the data. So in fact, I didn't use the full potential of this method because originally it was designed to work with low sample size, high dimensional data, and it has a great potential to explore, large data sets. And, from my experience, I can tell that this method works very fast. So another step forward is a new method, the extension of AGIVE that was developed also by Maron's group. And they call this data integration by analysis of subspaces. And it is very useful when some but not all blocks have shared components. So the next step is to use more blocks with more data that you have measured on the same set of individuals, genetic, proteomics, gene expression data. You can use it in many different ways. You can see that in my analysis, I used longitudinal data with baseline and follow-up in 2 different blocks. If you think about this, you can use several blocks with paired data, like left knees in one block and right knees in another block and hips in the third block and so on. So this is a very, very useful method for data with many measures. So, and for my study, I wanted to thank many faculty and other researchers that helped me to complete this analysis. It was completely new area for me, biomarkers post-injury. So there are many different people from Duke, UNC, and I really appreciate that help. And Yvonne can help with other acknowledgements.
Yes. Yeah. Thank you, Liubov. And yeah, I wanted to point out in particular that Virginia Krause has been very helpful to us. And as we've tried to even think about how to look at some of the biomarkers and interpret results from this study. And I do want to also acknowledge the team that worked with us on the IDEA study and the ground reaction force and NEOA data. Elise Borgert and Siqi Chang did so much with the analyses under the direction of Steve Marin, did a lot to help me understand a method that was very new and outside of my previous experience. And of course, Amanda Nelson and Richard Loser, Ashley Buck, and Steve Messier were immensely helpful with this work too. All right, so I open things up for questions.
Yeah, so I want to thank you both for this very informative presentation. And as Yvonne mentioned, we're happy to take any questions. So feel free to unmute yourselves and ask those questions. Or if you want to place something in the chat, I'll be monitoring that.
I have a question. Great presentation. Thank you for sharing. Yvonne, I was wondering with the bar plots that you explained before, the ground reaction force graphs of each of the components. I was wondering how you determined the loading importance, I guess. So like for example, in the first component, kind of like the assumption was that it was the faster gait speeds that were the primary component, my understanding of driving, like the way that the curves looked in the either positive or negative direction. But there were like other components, and so I was just trying to understand the bar plot a little bit more, and like how you determined like which factors were based on magnitude like more important than others, and like were those values on the bar plots like indicative of the magnitude of the relationship, if I'm understanding that
Yes.
correctly?
Yeah, that is correct. Yeah, and I can show an example just so I'll know what we're talking about. Sorry, let me share. Okay, so something like this with the walking speed. So what we were doing, a lot of this is, my understanding is visual, and Liubov, you can jump in and correct me if I'm wrong. So, essentially when we were trying to figure out how to interpret these loadings and how to communicate to others, communicate as we were writing the paper, we were looking at least at those that visually, where we could see that they had the greater magnitude loading, that would what we would use for describing the clinical traits data block and the movement scores data block, and then talking about how they were associated.
Yeah, this both magnitude and the sign, they determined by a drive. So all you need to do is just like upload data and grab them. So, and we use a lot of time to make sure that the sign is correct. So we just plot individual level data and color them by different variables to make sure that everything is correct. But this is the interpretation is similar to principal components analysis loading. So this is the same concept, just like with several blocks. So it's like if you think about this like principal components analysis, but like extended to more blocks, more data matrices. Yeah, but the loadings, they defined by both magnitude, so higher bars indicate more importance. And if for example, movement function and walking speed look in different directions, so it means that with increasing walking speed, the warm-up function is lower.
Does that help, Caroline?
Yeah, I was just wondering, like, that it definitely helps in my understanding. So thank you.
Yeah, good question. Thanks.
I actually wanted to follow up on that because as I was listening, it did sound to me very much as Liubov mentioned, akin to principal components. And so my question was, in terms of how to select how many blocks or components, like in principal components, it can be a little bit subjective. So I'm curious about the specific process here. And again, related to what Caroline asked, in terms of interpretability, as you're sort of picking off the variables that seem to be making the most impact, have you run into any cases where it's been hard to make clinical sense? I think, Yvonne, you mentioned maybe not being able to find a lot in the literature, but just maybe some guidance or thoughts you have on those issues.
Yeah, I can explain this.
Okay, well, and I can at least show what we used for, I'll show the slide for determining that we were going to look at 4 joint components. I don't know if you can add more to it, Liubov.
Yeah, so when you run a drive, like for example, in a MATLAB or in Python, so it will create you a lot of diagnostic plots. And the number of shared components, you usually like sit like that and wait until this plot, so and hope it will be more than one. So the number of shared principal components is the number of that bold black lines on the right. So sometimes there's nothing. So sometimes there's like one. In my case, it was only one. So, and the only manual step that you have to take when you run Agile is the number of variables from each block to use, and that is usually selected using script plot, similar to principal components analysis. But I have to say, that in DVAS, you don't even have to do even that. So it will be done everything by itself. So it's very, very useful, and the analyst is not using a lot of efforts to select. So you have to prepare the data, so to make sure that yeah, and sometimes like Todd said, the components are not very easy to interpret, so they don't make sense. Yeah, what is useful is to use other data sets to confirm that, but maybe this is something new that we didn't know before. Maybe this is just like a random result because this is data-driven analysis. And there are like several techniques to confirm these results, also developed by Dr. Maron's group to identify the stability of the results and modes of variations.
Yeah, and to add to that, sorry, Todd, I did not talk about the screen plots in this presentation, just in the interest of time. But that was what, as Liubov mentioned, we did those as well. That informed us of, looking at our rank choices, that we had 10 for the movement scores data block and 15 for the clinical scores data block. So that was that step that Liubov mentioned. And then I guess, Todd, you also asked about interpretation. So yeah, as you could probably tell, the first two components, we felt we understood those well, and they aligned with what we knew from previous research, our own work. For the third joint component, that was one where at least I could find that some work had been done. I think the one we struggled with the most, and I think this happens even with principal components, is kind of that last category, that fourth joint component. And that was where we felt we were actually seeing maybe two things going on with that joint component, as you saw in my presentation about talking about worse radiographic NEOA was one subgroup we thought we were seeing, and then we also thought that we were seeing something related to poorer health. But I know that as a group, we went around a bit with even some several versions of the manuscript thinking about that fourth joint component.
Great, thanks. Other questions? We maybe have time for one last quick question.
Can I ask a quick one? I was trying to remember the jump ACL study. The prediction of the jump landing test was really strong. And I know we didn't have the best biomarkers. We have better biomarkers now, but did any of the biomarkers correlate or associate with results from the jump landing test? Did we look at that?
No, we wanted to. I have not been able to get the data as of yet. But it's a great question.
It's actually a great idea.
Yeah, great job explaining everything.
Okay, and we'll leave it at that, but I want to thank both of our presenters, and I want to thank everyone for joining us, and hopefully you'll stay tuned for the next talk in this series. Thanks, everyone. Take care.
Thank you.